And now we move to the first clinical case. We go through the story of Elisa. She is a female, very young, 20 years old student, and she had the diagnosis of Graves' disease in October 2018 with a poor control of disease with methimazole. And she had a neck ultrasound scan in December, 1 year after, with the identification of a small suspicious nodule in the right thyroid lobe and some suspicious lymph nodes. Cytology showed Bethesda 5, and we also measured thyroglobulin in the washout from the needle used for the cytology on the lymph node, and thyroglobulin was extremely high, demonstrating the metastatic state of those lymph nodes. So on March 2019, she underwent total thyroidectomy and bilateral lymphadenectomy. And at histology, she had a multifocal papillary thyroid cancer from 1 to 14 millimeters in the right lobe and isthmus, a focal extension to soft tissues, and massive lymph nodal metastasis, as you can see here. So she was treated with radioiodine. At that time, TSH was 22 with thyroglobulin 180. And as you can see here, the whole body scintigraphy showed the uptake in the residue level and bilateral uptake in the lungs. A patient was treated with corticosteroids to prevent orbitopathy and also the development of lung fibrosis, and was scheduled for a second cycle of radioiodine. And after 6 months, she underwent a second cycle. At that time, thyroglobulin was increasing with respect to the previous one. And the whole body scan was absolutely negative. So after 4 months, we decided to perform a CT scan, and at that CT scan, we found lung metastasis, as you can see here, 12 millimeters, 6 millimeters, plus lymph nodal metastasis, which were also seen at the US scan. So this was a rare refractory disease, and we decided to follow up the patient. And this is the follow-up. Here we are here, and in the first 18 months, the patient had a this is thyroglobulin, and the structural stability of disease. But between October 2021 and June 2022, we observe a TG thyroglobulin increase with a doubling time less than 1 year. The diameter of lymph node increased, and at a PET FDG, we found the uptake from the bilateral lung nodules and also the uptake in the lymph nodes. What would you do now? And I am asking to the panelists, what would have you do between radioiodine, surgery, other diagnostic or systemic treatment? Lori.
So she's a young woman. I guess she's now 22 years old.
Yeah.
So if she were older, I would definitely consider doing a diagnostic biopsy of the lung nodules to confirm that it's a papillary thyroid cancer and not another malignancy. in a 22-year-old woman, I think that that's far less likely. And so I'm not convinced that that needs to be done. You have the confirmation of the diagnosis with the increasing thyroglobulin. So I think I might skip that. The other thing I want to know is what's driving the cancer. So I would definitely want to do a mutational analysis.
The mutational analysis.
So I think the question is do you have to do the mutational analysis off of a lung biopsy, or can you do it off of the primary?
Yes, the same, especially considering that is a young girl. I had no time to specify better before, but rearrangements are much more frequent in young people than in older people, or in cases who developed the disease in which the diagnosis was during the adolescence or the young age like this one. So there is a high probability that she has a rearrangement. So I would go for
other diagnostic, well, let's say.
Yes,
so
exactly.
Analysis.
Yes.
Questions from the audience, comments?
I'm Dr. Lin from Beijing, China. I was wondering what happened to his TSH during that TG escalation?
TSH was maintained suppressed. Undetectable, yes, undetectable during all the time, yes.
Okay,
yes,
then
in these cases, advanced cases, in young people, TSH is always below the normal range.
I see. I can see the first and second radioiodine therapy was done with the aid of RH-TSH.
The first one was done with a recombinant TSH, and the second one without withdrawal, with withdrawal of L-thyroxine.
Oh, I see. Okay. I got it. Thank you.
Okay. Okay. So what we did did the NGS assay on the primary tumor tissue, a chest CT scan.
We had another question.
Oh, sorry.
Sorry.
Sorry, thank you. Yogesh Pant from ENT from London. It's really a comment on the sort of presentation, this confluence between Graves' disease and differentiated thyroid cancer. I've managed more than a handful, and we get to the point where, not like this case, the TG is undetectable and ultrasound is good, but in the back of our mind we say, well, the TSH receptor antibodies are still positive, and maybe this is something that potentially might drive increased risk of recurrence. So we accept that in this patient we're suppressing the TSH, but of course we can't suppress the TSH receptor antibody. So I just wondered if you think there's any value in testing for that, in the same way as we might test for a TSH.
Yes, in this particular patient, we have no data, unfortunately, on TSH receptor antibodies. But we have another patient with metastatic with lung metastasis, and she actually has TSH receptor antibodies. But I think that they are not interfering with the course of her metastasis, which are absolutely stable in more than 10 years. But it is absolutely interesting also to check for TSH receptor antibodies in these patients. Mm-hmm. So, as I said, we did NGS and another chest CT scan, and we had a preliminary interview with the patient and the family, since this is a very advanced case, and thinking about a possible systemic treatment. So this is the result of the NGS analysis, and it was a RET fusion, which was confirmed by RT-PCR. And what about the situation? Here was the increase of thyroglobulin, and then thyroglobulin increased, as you can see here, and the chest CT scan demonstrated accordingly an increase in the diameter of lung metastasis 24 millimeters, and also of the lymph nodal metastasis. So this is a progressive disease. And what would you do now? Faculty. Radioiodine, lenvatinib, sorafenib, selpercatinib, pralsetinib.
Laura, may I ask you to refer the patient to our clinical trial looking at selpercatinib in patients who have iodine refractory RET fusion positive disease?
So you will choose selpercatinib in this.
I have a combo choice of D and A.
Okay.
In Boston, enrolled on a clinical trial.
Rossella.
A shameless plug.
We don't have clinical trials, so we do not have so many possibility to choose. And even if with some, I can say, concerns, because we know the side effects of lenvatinib, but probably I would start with the lenvatinib.
Yes, because in Italy, we, as you can see here, we have the possibility, in this case, just to use lenvatinib. Sorafenib is not reimbursed. Selpercatinib only in second line, and the pralsetinib is not approved. In Europe, which is the situation in Europe, lenvatinib yes, and sorafenib yes, and selpercatinib yes, and pralsetinib not approved. And as you can see here in the US, they are extremely lucky, and they can select between all these possibilities.
Laura, may I?
Yeah.
Yeah, because of course, if I would have the possibility to start with one of these drugs, because of the rearrangement, of course, either selpercatinib or pralsetinib would be the best. But the problem is sometimes in clinical practice what we can really use.
And if the age of the patient was 16 years old, the same selection?
Yes, if the disease is progressing, yes.
I agree. There is age-based dosing for adolescents with selpercatinib, and in the U.S. I do think that most providers would recommend selpercatinib or pralsetinib for the first-line therapy in a patient. I think it's clear that she has clinically meaningful progressive disease and she needs to be started on a therapy now and not wait for further progression. And I think that it's important to have a discussion with the patient and family, as you did, and discuss the knowns and unknowns about the efficacy of our drugs, the side effect profile, and then what we don't know. Is it better to use a gene-specific therapy first and then assume that there may be progression at some point in the future, and then we don't really know would a multi-kinase inhibitor therapy work well in that setting versus the other way around, where we know that there is activity with selpercatinib and pralsetinib in patients that have received a prior MKI. So those kinds of things are really important discussions, I think, to have with the patient. But I would say that most providers and patients do choose a gene-specific therapy first.
Okay. So upon the start of lenvatinib, but the same would have occurred if we have had the possibility to start with selpercatinib. And here you can see the start of treatment, the impressive response in terms of thyroglobulin and also in the decrease of the metastatic burden. Biochemical control of the disease, as you can see here, the decrease in all the neck and lung metastases. Here you can see the decrease of this metastatic location. But what about side effects? Well, we started with lenvatinib, and we started with the highest dose, and we had a lot of adverse events during time that we managed according to our experience and suggestions, and we also had to decrease the dosage of this drug. But sliding doors, what if we had started with the selpercatinib? In a patient like this, we have had the experience of very low adverse events, extremely rare grade 3 adverse event. We have found in some patients the chylous effusions, here one of them in the pelvis, but also in the chest, you can find them. But no really important adverse events. So here I have summarized the efficacy between selpercatinib and lenvatinib. As you can see here, the median progression-free survival is 20 months for selpercatinib and 18 months for lenvatinib. But the great difference is in the safety profile. The frequency of higher than 3 adverse events is 30% for selpercatinib and 76% for lenvatinib. Dose reduction is extremely more frequent for lenvatinib, as well as the discontinuation of the treatment. Okay. Have you other comments on this clinical case before we move to the next case?
I want to make a comment. Oh, okay, no, over there.
Yeah. Hi. So.
Hi, this is Theodora Papa from Boston. So in the event the patient were not in a clinical trial with Lori, and the patient were started on selpercatinib, when would you consider a diagnostic iodine scan to potentially think about uptake and repeating outside of a clinical trial control setting?
Yeah. No, this is a possibility. We can make it to see if the tumor redifferentiate under selpercatinib. There are no enough data to date to think about the possibility of true redifferentiation, but this is a possibility to check.
I agree. As you know, there are a couple of case reports of patients with RET fusion positive disease who have experienced redifferentiation, so, you know, it's certainly relatively safe to go down that route and try a combination therapy. And this is only a 22-year-old woman. And unfortunately, we have seen some progressive disease following beautiful responses to selpercatinib in patients with RET fusion positive papillary thyroid cancer. And, you know, Maria Cabanillas has said, I've heard her say a couple of times, you know, we're in this for the marathon, not for the sprint. And so we need as many tools in our toolkit as possible to make it through that marathon. And I think that there's, you know, certainly from the case reports, a suggestion that you can redifferentiate tumors. The question, I think, is can you really add to the clinical benefit, you know, rather than just seeing some uptake on the radioactive iodine? And that's why we need the clinical trials.
The problem with redifferentiation is not just the uptake of the radioiodine, but the organification of the radioiodine, so the re-expression also of the TPO, and to have a real effect of the radioiodine, not just the uptake.
The last comment that I want to say, I agree with Lori that we do not have evidences in how to start first with lenvatinib or with selpercatinib or vice versa. However, in these specific cases, this is a younger 22 years old. we have to take care also of the quality of life of this girl, and in the possibility to choose among them, probably to choose a drug that can impact less on her quality of life would be preferred. Also because these are drugs that have to be continued for a long time. We say until the evidence of a clinical benefit, and we hope that the clinical benefit will be as long as possible. So just this comment.
Just to add a word in favor of lenvatinib is that in young people, lenvatinib is very well tolerated, better tolerated than in older people. So the adverse events are not for our patient, but in general, they are well tolerated.
Could you comment on reproductive counseling and fertility counseling?
In all these young cases, we offer the possibility to cryoconservation of the oocyte in this case.
Of course, also recommend dual pregnancy prevention.
Yes.
And also we test for pregnancy prior to initiating therapy, and then occasionally we'll try to remember to circle back and check again.